Welcome to the deep dive. Today we're tackling eye, ear, nose, and throat disorders, or ENT. We've got a stack of detailed sources, and our mission really is to pull out the absolute need-to-know info for you.
Yeah, kind of cut through the noise.
Exactly. Think of it like a shortcut, so you can feel genuinely up to speed on common ENT issues, maybe even some serious ones. We'll hit some surprising facts and practical insights, too.
That's the plan. We're drawing heavily from Chapter 4 of the FMP 2024 workbook on these disorders.
Okay.
So, yeah, we're going to focus on understanding these conditions, spotting the red flags, the important stuff, and navigating treatment principles. Basically getting you the key knowledge fast.
All right, sounds good. Let's dive in. How about we start with something, well, pretty common, or at least commonly worried about, acute bacterial rhinosinusitis, ABRS.
Good place to start.
So first, maybe the bigger picture. Acute rhinosinusitis, ARS, that's just inflammation, right?
Yeah.
Sinuses, nasal passages, lasting up to 4 weeks or so.
Exactly. And it can be caused by allergens, irritants.
Yeah.
But mostly, it's viruses. Overwhelmingly viral.
Right. But then there's ABRS, that's the bacterial one.
Yes, that's when a bacterial infection sort of piggybacks onto a viral cold sometimes.
Okay. But you said sometimes. Is it rare?
It actually is surprisingly rare. Less than 2% of viral upper respiratory infections turn into ABRS.
Wow, okay. Less than 2%.
Yeah. And even when ABRS does happen, most cases, believe it or not, will resolve without any antibiotics at all.
That's huge, right? Because everyone wants antibiotics for a bad cold.
Exactly. Which leads us straight into a core idea for clinicians, when to actually use antibiotics. It's called empiric antimicrobial therapy.
Empiric therapy, meaning?
Meaning you're making an educated guess based on the likely suspects. So doctors are constantly asking, okay, what germs are most likely causing this specific infection? What's the best drug to target those germs? How likely is it that these bacteria are already resistant to common antibiotics? What's the risk if this treatment fails? And what's the minimum dose and shortest time needed to work safely?
So many questions. Okay, so when it is bacterial sinusitis, what are those likely suspects, the main germs?
Number one, far and away, is Streptococcus pneumonia. Gram-positive guy.
Okay.
And here's the kicker. Over a quarter of S. pneumo strains are drug-resistant.
Right.
They've changed their structure a bit to avoid the antibiotics.
Sneaky. Who's next?
Number two is Haemophilus influenza. That's a gram-negative one. And over 30% of those are resistant to penicillin because they make this enzyme, beta-lactamase, that just chews up the antibiotic.
Wow. Okay, so they fight back.
They do. And number three is Moraxella catarrhalis, another gram-negative. Over 90% of those make beta-lactamase too.
90%.
Yep. And interestingly, those top two, S. pneumo and H. flu, they cause other problems too. We sometimes call it TOMPS, conjunctivitis, otitis media, ear infections, meningitis, pneumonia, and sinusitis.
KMPS. Okay, useful mnemonic. So if most sinus trouble is viral and ABRS is rare, how do you tell the difference? What are the signs that say, uh-oh, this might actually be bacterial?
Great question. There are a few key things to watch for. One is duration. If your symptoms just drag on for more than 10 days without getting any better.
Okay, more than 10 days.
Or, this is a big one, if you start to feel better after a few days, but then suddenly get worse again, like a double sickness.
Ah, the double dip. Got it.
Also, a persistent toothache, but specifically in your upper teeth, under the sinuses.
Makes sense.
And then two slightly stranger ones. Cachosmia, that's smelling a bad odor that isn't actually there.
Huh. Weird.
And unilateral facial pain. So pain just on one side of your face, not both.
Okay, those are really clear pointers. So let's say the signs point to ABRS. What's the game plan? What antibiotics are typically used first?
For adults, standard initial treatment is often amoxicillin. Frequently, it's a high dose, specifically to overcome potential resistance in that S. pneumonia.
Right, the number one culprit.
Exactly. Or another really common choice is amoxicillin clavulanate. You might know it as augmentine.
Yeah, what does the clavulanate do?
So the clavulanate inhibits that beta-lactamase enzyme we talked about, the one that H. influenza and M. catarrhalis use to break down penicillin-type drugs. It basically protects the amoxicillin.
Ah, clever. Like a bodyguard for the antibiotic.
Kinda, yeah. And really importantly, some antibiotics that used to be common are generally not recommended now for ABRS because resistance is so high.
Which ones are those?
We're talking about macrolides, so azithromycin, Z-Pak, clarithromycin, erythromycin, and also TMP-SMX, which is Bactrim. Too much resistance these days.
Good to know. What if someone's allergic to penicillin, though? What are the options then?
Good question. If it's a beta-lactam allergy but not severe, like anaphylaxis, then often a second or third generation cephalosporin can be used. things like ceftonir, cefidoxime, cefuroxime. But if there is a history of anaphylaxis to penicillin, then the options shift. You might look at doxycycline, or a class called respiratory fluoroquinolones, like levofloxacin or moxifloxacin.
Fluoroquinolones, I feel like I've heard warnings about those.
You probably have. The US FDA actually put out an advisory saying that for conditions like acute sinusitis, the potential side effects of fluoroquinolones often outweigh the benefits if other treatment options exist. So they're not usually a first choice unless necessary.
Right. Important context.
And also just a quick note on pregnancy risk. Doxycycline is category D, definitely not recommended. Fluoroquinolones are C, used with caution. Amoxicillin and many cephalosporins are generally considered safer options in pregnancy.
Okay, so what if that first antibiotic, whatever it is, just doesn't seem to be working after, say, 3 to 5 days? What happens next?
Well, if it's a mild or moderate case that's not responding, the clinician might switch to high-dose amoxicillin and clavulanate, or maybe one of those cephalosporins. If it's a more severe infection failing initial therapy, then those respiratory fluoroquinolones might come into play, again, keeping that FDA advisory in mind.
Right.
But here's a really interesting point about treatment failure in primary care.
Yeah.
More often than not, it isn't actually because the bacteria are super resistant superbugs.
Really? What is it then?
It's often much simpler. Prescribing the wrong antibiotic for the likely pathogen in the first place, or prescribing the right antibiotic but at too low a dose to actually kill the bacteria effectively.
Ah, so it comes back to those initial prescribing decisions.
A lot of the time, yes, which highlights how important getting the diagnosis and the initial treatment choice right is.
Definitely. And speaking of medications, this brings up the whole issue of drug interactions, right? That seems like a huge patient safety concern.
It absolutely is, and it often involves these things called CYP450 enzymes in your liver.
CYP450 sounds technical.
It is a bit, but the concept is pretty straightforward. Think of these enzymes as little processing plants in your body. They metabolize or break down a huge number of drugs, maybe around half of all prescriptions.
Okay, processing plants.
I like that. So the drugs being processed are called substrates. Lots of common meds are substrates for one particular enzyme. CYP453A4, things like sildenafil, Viagra, atorvastatin, simvastatin, alprazolam, Xanax.
Right.
Now, other drugs can act as inhibitors. They block or slow down these processing plants.
Okay, inhibitors slow things down.
Exactly. So you take an inhibitor, like certain antibiotics, erythromycin or clarithromycin, are classic examples, along with a substrate processed by that same enzyme, like simvastatin.
Oh.
The simvastatin doesn't get broken down as fast. Its levels build up in your body, and that can increase the risk of side effects like serious muscle problems called rhabdomyolysis.
Wow. Okay, that's scary.
Or taking an inhibitor with alprazolam could lead to way too much sedation.
Got it. So inhibitors build up potential problems. What's the opposite?
The opposite is inducers. These drugs speed up the processing plants.
Okay, speed things up.
Right.
Yeah.
So if you take an inducer, like the herbal supplement, St. John's wort is a common one,
Yeah.
along with a substrate, say oral contraceptive pills.
Oh, I see where this is going.
The inducer speeds up the breakdown of the contraceptive hormones. Their levels in your body drop, and you could end up with treatment failure, like contraceptive failure.
Yikes. That's a really big deal.
Huge.
Yeah.
So the bottom line is always tell your doctor and pharmacist everything, taking prescriptions, over-the-counter meds, vitamins, supplements, everything.
Absolutely crucial. Okay, great explanation. Let's pivot now to the ears. Common stuff there. What about that feeling of ear fullness, maybe muffled hearing after you've had an ear infection? What's going on there?
Yeah, that's a really common scenario.
Mm-hmm.
It usually points to the difference between a true active infection, we would call acute otitis media, or AOM,
AOM, got it.
and just having fluid trapped behind the eardrum, which is called otitis media with effusion, or OME, sometimes called serous otitis.
OME. So AOM is the infection, OME is just fluid. How do they look different to a doctor?
With AOM, the eardrum usually looks quite red. It's often bulging outwards, and it doesn't move when the doctor puffs a little air at it. And often there's a fever and ear pain.
Okay, red, bulging, painful.
Pretty much. With OME, the eardrum might look opaque, maybe yellowish or even bluish. You might actually see air bubbles or a distinct fluid line behind the eardrum. And importantly, it's usually not painful, just that full, muffled feeling.
So the treatment must be different too.
Totally different. AOM, the infection, usually needs pain relief, and often antibiotics are prescribed, although, like sinusitis, many AOM cases do resolve on their own. especially in slightly older kids and adults.
Right.
OME, the fluid, generally doesn't need antibiotics. The focus is on treating whatever caused the fluid buildup in the first place, like maybe allergies or a recent cold. The fluid itself usually clears up on its own over weeks or sometimes months.
Okay. And that muffled hearing, does that relate to different types of hearing loss?
It does. OME is a perfect example of conductive hearing loss. That's when sound waves aren't conducted efficiently through the outer or middle ear to the inner ear. Think earwax blockage, or fluid, like in OME.
Conductive. Makes sense. What's the other type?
The other main type is sensorineural hearing loss. That involves damage to the inner ear itself, the cochlea, or the auditory nerve pathway to the brain. Age-related hearing loss, presbycusis, is a common example of sensorineural loss. Noise exposure to.
Okay. Conductive versus sensorineural. Can you tell them apart easily?
Sometimes clinical history helps, but a simple bedside test using a tuning fork, called the Weber test, can give a clue. If you place the vibrating fork on the middle of the forehead, someone with conductive loss in one ear will often hear the sound louder in that affected ear.
Interesting. Louder in the bad ear means conductive.
Generally, yeah. It's because the ambient room noise isn't getting through the blockage as well, so the bone conduction seems louder by comparison.
Fascinating. Okay, let's switch from ears to eyes. Allergic conjunctivitis, itchy, red eyes. Pretty common, right?
Very common. Typically, it affects both eyes. They're itchy, look red. We call that hyperemic, both on the white part, the bulbar conjunctiva, and the inside of the eyelids, the palpebral conjunctiva.
And sometimes there's discharge.
Yeah, usually a small amount, often described as kind of ropey or stringy and pale yellow or whitish. The key symptom, though, is usually the itching.
So what's the fix?
For straightforward allergic conjunctivitis, the best bet is usually an ocular antihistamine. Eye drops you can get over the counter or by prescription. They work directly on the eye tissue.
Okay, simple enough. But not all red eyes are just allergies. When should a red eye really worry us?
This is critical. There's a classic triad of symptoms that screams, refer to ophthalmology immediately.
Okay, what's the triad?
A red eye, plus significant eye pain, plus any new onset change in vision blurring, loss of vision, anything like that.
Redness, pain, vision change. Got it. Why the urgency?
Because that combination can signal serious, potentially sight-threatening conditions like acute glaucoma, uveitis, or infectious keratitis. Things that need specialist diagnosis and treatment right away to prevent permanent vision loss.
Definitely something to remember. Now, speaking of vision changes, let's talk about aging. What happens when people hit their mid-40s and suddenly can't read the menu?
Yes, the classic arms aren't long enough syndrome. That's presbyopia.
Presbyopia.
Yeah, it's just the gradual blurring of near vision. Happens to pretty much everyone. It usually starts becoming noticeable around age 45. People say exactly that. I suddenly need reading glasses.
What causes it? Is the eye changing shape?
Not really the shape, but the lens inside the eye. Over time, the lens naturally becomes harder and less flexible. It just can't change focus easily to look at things up close anymore.
So it's inevitable, basically.
Pretty much universal, yeah.
Yeah.
By age 45, nearly everyone will need some help for reading, whether it's reading glasses, bifocals, or progressive lenses.
Okay. What other eye changes come with age?
Cataracts, definitely. Senile cataracts are very common. That's when the normally clear lens inside the eye gradually becomes cloudy or opaque.
So it's like looking through a foggy window.
Exactly. It causes progressive dimming or blurring of vision, often worse with glare, like from headlights at night. The good news is cataract surgery is incredibly common and effective. They remove the cloudy lens and replace it with a clear artificial one.
Okay. What about macular degeneration? I hear about that a lot.
Age-related macular degeneration, or AMD, is another big one. It affects the macula, which is the central part of your retina responsible for sharp, detailed, straight-ahead vision.
The really important part for reading and faces.
Precisely. AMD causes painless distortion or loss of that central vision. Straight lines might look wavy, or there might be a blurry or blind spot right in the middle.
Can doctors see it?
Yes, on eye examination, they might see characteristic changes, including little yellow deposits under the retina called drusen.
Are there different kinds?
There are two main forms. The dry form is more common, develops slowly over years or decades. There aren't many treatments for dry AMD, so prevention, like not smoking, eating leafy greens, is key.
And the other form?
The wet form is less common but more severe. It develops much faster, often over weeks or months. Abnormal blood vessels grow under the retina and leak fluid or blood.
That sounds bad. Can it be treated?
Yes, wet AMD can often be treated, usually with injections of medications into the eye that stop those abnormal vessels from growing anti-VEGF therapy, or sometimes with laser treatment. Early detection is really crucial for wet AMD.
Absolutely. Okay, one more major eye condition, glaucoma. What's the key thing to understand there?
Glaucoma is basically damage to the optic nerve, the cable connecting the eye to the brain, usually associated with high pressure inside the eye. The real danger is that it can cause irreversible vision loss, often starting with peripheral vision.
Peripheral vision first, so you might not notice it right away.
Exactly. That's the problem with the most common type, open-angle glaucoma. It's usually painless, and the vision loss is very gradual, sneaking up from the sides. That's why regular eye exams, including pressure checks and optic nerve evaluation, are so important for screening, especially as you get older.
Open angle. Is there another type?
Yes, angle closure glaucoma. This one is much less common, but it's an absolute emergency.
Emergency. How so?
It happens when the drainage angle inside the eye suddenly gets blocked, causing a rapid, severe spike in eye pressure. Symptoms are dramatic. Intense eye pain, redness, blurred vision, seeing halos around lights, sometimes nausea and vomiting.
Wow, okay. That sounds terrifying.
It is. It needs immediate treatment in an ER or ophthalmologist's office to lower the pressure quickly and prevent permanent blindness.
So very different presentations, but the goal of treatment for both is the same.
Fundamentally, yes. For both open angle and after the emergency phase of angle closure, the goal is to lower the intraocular pressure to protect the optic nerve. This is usually done with prescription eye drops, sometimes laser treatment, or surgery.
Okay, that clarifies glaucoma really well. Let's switch gears back to the respiratory system for a bit. COVID, flu, common cold, they can all feel similar sometimes. Any key things that help tell them apart?
Yeah, it can be tough, especially early on. But there are some tendencies. That sudden, complete loss of taste or smell was a really strong indicator for COVID-19, much less common with flu or colds.
Right, the anosmia.
Exactly. Sneezing, on the other hand, is super common with a cold, maybe less so with flu or COVID.
Okay.
And significant shortness of breath or difficulty breathing, that's a much bigger red flag for COVID-19 or potentially pneumonia, complicating the flu, rather than just a simple cold. Of course, testing is the only way to know for sure.
True. Okay, let's talk sore throats, pharyngitis. How do you figure out if it's just viral or if it's actually strep throat?
That's a really important distinction to make. Viral pharyngitis, which is the most common cause of sore throats, usually comes along with other cold-like symptoms, clear runny nose, maybe a cough, hoarseness.
Kind of feels like a cold with a sore throat.
Pretty much. Strep throat, which is caused by that Groupe beta hemolytic strep bacteria,
Or gay BHS.
DBHS,
Got it.
often presents differently. It tends to be a sudden onset of a really sore throat, often with fever, headache, and noticeably swollen, tender lymph nodes in the front of the neck.
Tender nodes, okay.
And when you look in the throat, you might see redness, swelling, and sometimes white patches of pus. On the tonsils, we call those exudates. You usually don't have the runny nose or cough with strep.
Okay, so sudden onset, fever, swollen glands, maybe exudates, but no cold symptoms.
That's the classic picture, yeah. Though it's not always textbook. But it's worth remembering, strep throat is actually much less common in adults than kids. Only maybe 10% or so of adult sore throats are strep.
Only 10%, but we hear so much about it. Why is treating it so important then?
Two main reasons. First, untreated strep throat, although rare now, can lead to serious complications down the road, particularly rheumatic fever, which can damage the heart valves.
Ah, right.
Rheumatic fever.
Second, treating it with antibiotics shortens the duration of illness slightly,
Yeah.
but more importantly, it reduces the period when someone is contagious, helping to prevent spreading it to others.
Okay, makes sense. But you don't treat everyone. What about carriers?
Right. People who carry the JABHS bacteria in their throat but have no symptoms, asymptomatic carriers generally don't need antibiotic treatment. They're at low risk for complications and aren't thought to spread it easily.
Got it. So if it is diagnosed as strep throat, what's the usual antibiotic treatment?
The gold standard really is still penicillin V taken orally, usually for 10 days. Amoxicillin is also very commonly used, often preferred for kids because it tastes better. It's also taken for 10 days.
10 days seems long.
It's necessary to fully eradicate the bacteria and prevent those complications. If taking pills for 10 days is going to be a problem, like maybe adherence concerns,
Yeah.
a single intramuscular injection of long-acting benzathine penicillin G is an option, though generally oral treatment is preferred if possible.
Okay. And what about penicillin allergies here? Same alternatives as for sinusitis?
Similar options, yes. If there's a severe beta-lactam allergy, Then macrolides like azithromycin or clarithromycin or clindamycin are alternatives.
But you mentioned resistance with those earlier.
Exactly. That's the catch. Up to 35% of group A strep strains might be resistant to macrolides in some areas. So they're alternatives, but maybe not always the best if penicillin isn't an option. Clinicians have to weigh that.
Right. What if someone keeps getting strep throat over and over?
For truly recurrent, culture-proven strep infections, sometimes the thinking is there might be another bacteria hanging out in the throat, one that produces that beta-lactamase enzyme and protects the strep from penicillin.
Like a bodyguard again?
Sort of. In those cases, switching to an antibiotic combo like amoxicillin clavulinate or using clindamycin might be considered to wipe out both the strep and its potential protector.
Fascinating stuff. Okay, let's shift to allergic rhinitis AR. Hay fever, seasonal allergies. That miserable combo of sneezing, runny nose, congestion, itching. How do we tackle that effectively?
It's definitely a multi-step approach. And surprisingly, the first-line therapy isn't actually medication.
No, what is it?
Allergen avoidance and environmental control. Sounds simple, but it's key. Things like keeping windows shut during peak pollen season, using dust mite covers on bedding, HEPA filters, washing hands after petting animals. Reducing exposure makes a big difference.
Right. Avoid the triggers. But what about meds for managing symptoms?
Okay, so for meds, we think about controllers, things you use regularly for prevention, and relievers, things you use for quick symptom relief.
Controllers and relievers. Okay.
The number one controller therapy, the first-line medication choice, is intranasal corticosteroids. Sprays like fluticasone, mometasone.
The nasal sprays, why are they first line?
Because they're highly effective at reducing all the main symptoms: congestion, runny nose, sneezing, itching. They work by reducing inflammation in the nasal passages. The downside is they take a few days to reach full effect, so you need to use them consistently.
Okay, so they're for prevention, not instant relief.
Exactly. Intranasal antihistamine sprays, on the other hand, work much faster, within minutes to hours, so they can be good controllers or relievers.
What about pills? Antihistamine pills?
Yes, oral antihistamines are mainly relievers. They're good for itching, sneezing, and runny nose, but not great for congestion. We strongly prefer the second-generation ones like loratadine, cetirizine, fexofenadine.
Claritin, Zyrtec, Allegra?
Right, because the older first-generation ones like dipisenhydramine, Benadryl, cause significant drowsiness and other side effects. Not ideal for regular use.
Definitely want to avoid the drowsiness. And for the itchy eyes that often come with allergies.
Ocular antihistamine eye drops are the way to go there. They work directly where the problem is.
Makes sense. Are there any allergy treatments that are generally not recommended?
Yes, a couple of important ones. Leukotriene modifiers, like Montelukast, Singulair, used to be prescribed more often, but now there's an FDA-mandated warning about potential serious neuropsychiatric side effects, things like agitation, depression, suicidal thoughts. So it's not a first-line choice anymore.
Wow, okay. Good to know. Anything else?
Systemic corticosteroids, prednisone pills, or steroid shots.
Yeah.
While they work really well, they have significant potential side effects, like adrenal suppression, bone density loss, mood changes, weight gain. They should really only be used for very severe short-term flare-ups, not routine management.
So nasal steroids good, oral steroids used with caution?
Basically, yes. Stick with topical treatments like nasal sprays and eye drops as much as possible for long-term control.
Got it. Now thinking about aging again, we talked vision and hearing, but what about smell and taste? Do those change too?
They definitely do. Loss of smell, which is anosmia or just diminished smell, hyposmia, becomes more common with age.
Why does that happen?
It's mostly due to natural neural degeneration. The nerve cells involved just don't work as well over time, and things like smoking can really accelerate that decline.
And does that affect taste?
Absolutely. So much of what we perceive as flavor actually comes from smell. So when your sense of smell declines, your ability to discriminate fine tastes often goes down too. Food might seem bland.
Ah, okay. And you mentioned presbycusis earlier, the age-related hearing loss. Can you elaborate on that a bit?
Right, presbycusis specifically affects the sensitivity of the eighth cranial nerve, the auditory nerve. What's characteristic is that a person can often hear that someone is talking, but they have trouble understanding the words, especially if there's background noise.
Hear, but not understand. That must be frustrating.
Very. It can lead to social isolation. Hearing aids can definitely help amplify sounds and improve clarity. And communication strategies are key. Face the person, speak clearly, reduce background noise, make sure they can see your lips.
Simple things that make a big difference. Okay, let's wrap up with a very serious topic. Oral cancer. Specifically squamous cell carcinoma, SCC. What's the lowdown?
SCC is unfortunately the vast majority of oral cancers, about 95% of cases.
95%. Wow. What causes it?
Well, the traditional big risk factors are tobacco use, smoking, or smokeless tobacco, and heavy alcohol consumption. Those are huge. But increasingly, we're recognizing the role of high-risk strains of the human papillomavirus, HPV, particularly HPV-16.
HPV, like the one that causes cervical cancer.
Exactly. Long-standing infection with certain HPV types is a significant contributing factor, especially for cancers in the back of the throat, the oropharynx. Other factors include being male and simply getting older.
So what does it look like? How would someone know?
Clinically, it often presents as a lesion in the mouth, could be on the tongue, floor of the mouth, gums that looks like an ulcer or maybe a growth, and crucially, it's often painless, especially early on. And it doesn't heal, it just persists for weeks or months.
Painless is tricky. People might ignore it.
That's the danger. Another key sign can be a lump in the neck, usually under the jaw, a swollen lymph node. Typically, it feels firm, it's not tender, and it doesn't move around easily. That often means the cancer has spread.
Okay, so let's take the example case. Edgar, 75, former smoker, has COPD, finds a painless lesion on his tongue that's been there a while. What absolutely needs to happen next?
Immediate referral. That scenario screams potential SCC. He needs to see an ENT specialist or an oral surgeon right away for a biopsy of that lesion. Get a tissue sample to confirm if it's cancer. And likely imaging tests like a CT or PBT scan to see if and where it might have spread. Early detection and treatment are paramount.
Absolutely critical. Wow, okay. We have covered a ton of ground today, from sinuses and allergies to ears, eyes, aging senses, and even oral cancer, a real deep dive into ENT.
We really did. I think the big takeaway really is just how much careful observation and informed thinking matter in dealing with these conditions.
Yeah.
Yeah, recognizing those subtle differences in symptoms, understanding why certain treatments are chosen, and knowing when something crosses the line from common annoyance to I need specialized care. That can make all the difference.
It really empowers you, the listener, doesn't it? To be a better advocate for your own health, ask smarter questions, understand the answers you get back.
Absolutely. Which leads to a final thought, maybe something for you to mull over. How can really understanding these details, the nuances of symptoms, the logic behind treatments for these ENT issues, how can that change the way you approach your own healthcare or how you have loved ones navigate theirs? Think about how these insights might shift your conversations with doctors or even just how you manage things yourself day to day.